The moment a patient encounter ends and the documentation hits the chart, your practice's revenue is at risk. This risk exists because CPT coding has become a highly volatile precision function. Today, a single missed modifier can trigger a 60-day denial nightmare. This line chart plots the rise of initial claim denial rates. In just a few years, rates climbed from 10.2% to 11.8%. Expanding to the broader industry, 60% of medical groups reported an increase in denials compared to a year earlier. Most of these denials trace back to routine documentation issues, like a single missed modifier, incomplete diagnosis specificity, or simple bundling violations. Individually, these look like small administrative errors. Cumulatively, they add up to between 10 and 15% of a practice's annual earnings in lost or delayed revenue. This bar chart visualizes that scale. For a practice generating $10 million annually, those coding errors represent up to $1.5 million in revenue leakage every year. Treating CPT coding as simple data entry creates a persistent risk to the practice's financial survival. The difficulty lies in the constant movement of the rules. Every year, the AMA updates the CPT code set, while payers layer on their own plan-specific bundling logic and medical necessity thresholds. For every encounter, a coder must navigate ICD-10, CPT, and HCPCS code sets simultaneously. Every step is a chance for an error. This area chart shows a spike in outpatient coding denials. They rose 26% between 2024 and 2025, following a 126% increase the year before. The scanning nodes represent Care AI-assisted review tools, catching inconsistencies that once slipped through human review. Then there is the updated CMS 60-day overpayment rule. Effective January 2025, it requires providers to report and return identified Medicare overpayments within 60 days. Under this rule, inaccurate coding moves beyond delayed payments and creates the risk of active recoupment of funds your practice has already spent. These shifting standards require specialty-specific knowledge and continuous education that generalist billing staff rarely have the capacity to maintain. Finding and keeping the credentialed coders required to navigate these rules is increasingly difficult for practice managers. This waterfall chart breaks down the total loaded cost of an in-house coder. Stacking salary, payroll taxes, and benefits, the expense reaches $80,000. Adding this penalty block highlights turnover. With staff churning at 33%, replacing a coder costs an additional $30,000. Demand for these professionals is projected to grow by 7% through 2034, forcing mid-size practices to compete with major hospital systems for the same talent pool. When a practice loses a coder and hires a cheaper generalist, the quality spiral begins. Claim denials rapidly increase. Staff spend time on appeals and less time on prevention. Specialty groups are hit hardest. Complex modifier requirements for orthopedics or cardiology require specific expertise. Without it, denials become almost certain. For most mid-size practices, the perceived control of in-house staffing is often outweighed by these high fixed costs and turnover risks. A much more stable approach involves integrating a dedicated, specialized team directly into your clinic's existing digital infrastructure. This matrix compares the financial models. An in-house coder costs $80,000 annually, while a dedicated Staffingly seat is $399 weekly, a 60 to 70% reduction. The operational impact is clear. You eliminate the benefits load, training overhead, and the financial exposure to staff turnover. Staffingly provides dedicated AAPC and AHIMA-credentialed teams. They aren't shared across accounts. They act as a true extension of your practice. They work natively inside your EMR, including Epic, Athena, and eClinicalWorks. This eliminates the lag associated with typical remote workarounds. Security is handled through HIPAA, SOC 2 Type 2, and HITRUST frameworks, matching or exceeding the compliance posture of an in-house team. This dedicated model prevents cognitive overload. It ensures coders focus solely on accuracy, rather than being distracted by billing or denial management. This arrangement trades physical proximity for specialized EMR integration and predictable monthly costs. To maintain precision at scale, specialized teams use intelligent routing to process complex claim data without creating bottlenecks. Staffingly uses AI-augmented tools to distribute work based on coder specialty and the specific complexity of each claim. Automated audit sampling also flags potential errors before claims are submitted, allowing for proactive corrections. This quadrant chart plots cost against accuracy. Generalist in-house billing often falls into the high-cost, high-error zone. Staffingly moves into the high-accuracy, low-cost quadrant, keeping error rates below 1%. Combining credentialed human expertise with predictive AI oversight delivers a level of precision that generalist staffing models struggle to replicate. The final barrier for most practices is the perceived difficulty of changing their existing workflow. This timeline shows the 14-day go-live path. From initial kickoff to full EMR integration and protocol mapping, the transition is designed for minimal disruption. The first 14 days act as a risk-free pilot. Practices can evaluate the accuracy and speed of the team before committing to a long-term arrangement. To ensure visibility, administrators receive weekly KPI dashboards tracking throughput and accuracy. You see the ROI in your data every week. This is a strategy built for mid-size groups and multi-specialty clinics looking to resolve the turnover and denial cycles. Practice leaders need to shift from seeing coding as a staffing hurdle to treating it as a specialized risk management function. This precision-based strategy secures the revenue